No, it's because I haven't started yet. So let me just open the thing and welcome people who are willing to join.
Okay.
I see 1, 2, so they'll start joining us now. I think they might have been struggling to come in because we didn't open it. Sorry about that, Sarah. I had you on the call, but I think you're on mute and not available. And we are also hoping to get Joy on the line so that she can talk about it. Perhaps as we are waiting for participants to come on board, Aicha, do you mind introducing yourself to me briefly?
Yes, hello, good afternoon.
Hi.
My name is Aicha. It's not the first time that I'm seeing you because I have been doing this session every time.
All right, great. We're hoping to, I didn't send out a registration requirement. I must actually just change these things behind me. But I actually had, let me just remove this. Something. The problem has been that Joy hasn't come on board, so I'm going to have to figure out how how we function without Joy on the telephone. Let me just see if we can communicate with Joy quickly to see what's going on. She says she cannot access the WONCA platform. I sent emails other than I've got to go test patients. Oh, it's early in the morning. Okay, let's just quickly see how it goes. All right, well, welcome to everyone. We have some attendees and perhaps we can encourage the conversation a bit slightly differently. We basically have members of the WHO here. Perhaps we can do a quick round of introduction and we can allow all our guests who are there, and I'll just read them briefly and allow them all to talk so that we can have a conversation while we are proceeding. So I'm going to unmute all of you and you have the opportunity to introduce yourself and we can get going about chatting around. So let me unmute everyone. So just quickly, my name should be Musa. I'm a family physician working in Soweto in South Africa, and I'm trying to get a review of what's going on in Africa and particularly the response to COVID. We had discussed something about South Africa before, and we were planning to talk about Kenya today. Joy Mugambi was going to be presenting on it with some colleagues locally. I would hope that she joins us. Nonetheless, let me start by asking all the panelists who are on here to introduce themselves, and then we will continue with the panelists and have a discussion. Even if it's general, I see that Joy has some challenges to join us, and so we can just have a general discussion. My apologies for that difficulty. So Aicha and Sarah, perhaps you can start, and then we'll go to our attendees and then continue from there.
Thanks very much. So my name is Sarah Hess, and I work at the World Health Organization in Geneva, Switzerland, in the Health Emergencies Program. Prior to the COVID-19 outbreak, I was involved in the preparedness side of the emergencies work. During the response, I am more involved in the risk communication, partnerships, and dissemination of information side of the work. I'm really happy to be here. My heart is very much in Africa. I was born and grew up in Zimbabwe and went to university in South Africa. So yeah, thrilled to be.
I didn't know that.
Yeah, I went to Rhodes University.
Oh, wow. So you're a South African, an African. Welcome. Thanks, Sarah. Aicha, do you want to introduce yourself?
I'm Aicha. I'm a nurse midwife, public health officer, worked for more than 20 years abroad, mainly in Africa and Southeast Asia. And now currently I'm working with WHO in the emergency program on COVID. I have a huge experience on polio and Ebola outbreak.
Well, thank you very much for joining us. Let's just go through the attendees, and I think Amanda's unmuted herself, so Amanda, go for it. We were really pleased that Amanda Howe, the previous president, past president of WONCA, is able to join us. Amanda, go ahead.
Hi, I hope you can hear me. Is it okay?
Yes, yes,
perfect.
It's great.
So
Thank
I'm
you.
just, I'm always interested in the situation for Africa. And because I had the opportunity this afternoon, I just wanted to join and listen in. And, from the UK perspective, colleagues often saying to me, oh, I imagine it's much tougher in Africa, but we don't really know what's going on. And Prof. Musa has been giving very good updates through WONCA, but I thought I would just like to listen a little bit more to understand on the ground how it is. And people discussing, whether the number of cases that actually are happening are entering the data. It's always been an issue for Africa with, new infections, sometimes the data gathering not so easy. So I think just wanting to learn more, really. Thank you.
Thank you very much. I think anyone can sort of go for it. Andre is up next. Andre, do you want to introduce yourself? I'm going to just go alphabetically, so please feel free to mute and unmute yourself and present yourself. Andre?
Prof, yes, thank you. I was invited by a colleague that I met at one of the NHI sessions in Gauteng, and they invited me to that. And since then, I've been following what you were doing. I'm not a medical practitioner, however, I am very vocal in terms of transformation of the healthcare system in South Africa in general. And obviously, this impacts us in South Africa, but globally also. And I'm just interested in the topic and listening and learning from experts like yourself and our World Health Organization experts.
Great, thank you very much. We're really pleased that you joined us. Non-health people are actually very valuable in this whole discussion. We get wrapped up in our story. So thank you, Andre, for joining us. Beth, you can introduce yourself. Beth Tritter.
Certainly. Thank you, Professor. This is Beth Tritter. I'm the Executive Director of the Primary Healthcare Performance Initiative, and I'm in listening mode today. We're very focused on how we can be supporting countries at this time in terms of strengthening primary healthcare and maintaining essential services, and I am hoping to learn from all of you.
Great, thank you. Really pleased you joined us. Thanks, Beth. I see after that we've got Christina. Christina, will you be able to tell us a little bit about yourself? Joseph, anyone of you? Anyone who wants to present themselves, please feel free. Joseph Choke. Kaya Belknap. Kezia, do you want to introduce yourself? Steve, you should be there. I hope you will introduce yourself. Kezia, go for it.
Hi, my name is Kezia Lewins. I'm a sociologist with an interest in health. We're currently looking at doing a project looking at COVID and sort of government and healthcare sector responses. So I've been very interested in looking at the WONCA and listening to everything and learning from you all. So I'm very much, glad to be a part of this and learning all the different kind of responses. So thank you for having me. Thank you.
Thank you, Kezia, for joining us. Anyone else would like to introduce themselves? Steve, I think others have joined us, Rudolph. So I'll give you a few seconds. Anyone who would like to introduce themselves? Steve, yes.
Hi, Shabir. Steve Reid here from
welcome.
Cape Town. I'm head of primary healthcare at the University of Cape Town. Very involved in the Cape Town COVID epidemic and the emerging. Every day is a new surprise. Yeah.
Sure. Every day is new. Good. Anyone else would like to introduce themselves while we're doing that? I'll just put out this, but if anybody would like to step up to introduce themselves, just unmute yourself. If you can, just put out this little information while we wait if anybody would like to introduce themselves. Otherwise, we'll go into discussion. I'm going to, as I said, Innocent. Welcome, Innocent.
Yes, sorry, Shabil, I had just got disconnected for some reason I didn't know.
No,
I am Innocent Besigye. I'm a family physician. I work at Makerere University in Kampala, Uganda. And I also work with the Shabil on promoting AfroPHC, and I'm also a member of the Prima Farmed Network, which is the academic part of WONCA Africa. Thank you.
All right. If you can just fill up that poll. If you're not, I'm going to switch it off in the next few seconds. We haven't got too much of feedback from it, so I'm not going to give you the feed results of it. But I think if you can, if anybody else willing to introduce themselves, Anastasia, anybody from any other African country, we'd really appreciate, because I'm going to just have this as an open discussion. I think I've shared before what's going on in South Africa. I really think that, well, others in South Africa can share what's happening, but I'd be very interested to hear what's happening in other African countries, and if some of the colleagues on the call could actually use that. As I mentioned earlier, unfortunately, Joy seems to have a challenge and is not going to be able to join us. So I plan to get an idea of what's going on in Kenya is going to have to wait. But if there's anyone here able to speak, please introduce yourself so that we could get some feedback from you. Okay, well, I think that I'm going to just do some quickies so that just we have a quick sense of what's happening in Africa. I'm just pulling up a virus tracker, coronavirus tracker that I use that shows up what's going on in Africa and gives us a good idea. It looks like we have about 18,000 visits, 18,000 cases that are confirmed. And from what we have in Africa, the sort of hotspot is South Africa, and within South Africa, it's Gauteng as that small province, and in that province is Johannesburg, the district I'm working in, and that I'm busy with stuff happening, and I can share a little bit of that, but I've talked enough about what's going on in South Africa. It seems, I'm not sure what country this is, it looks like it's Nigeria and also maybe DRC. I'm not too familiar with my geography. Ghana, those look like places that are growing. But these are North Africa, so they're not part of the WHO Sub-Saharan Africa. So I think the hotspot is South Africa. I see that there is an emerging problem, not so much, somewhat in Kenya, Uganda. And so I hope that we can have a little bit of a discussion around that with Innocent and other persons that want to share what's going on. Perhaps we could, just looking at the trajectory in Africa, it's seen as quite unique. It's not the exponential growth. And I think the key questions, as Amanda raised, is it because we're not testing? What's going on? Are we missing what's going on? I think that's a really important question. I can share some of the South African problems later. Perhaps what would be useful, and I can come back to South Africa, is comments from Innocent, I think, about what's going on in Uganda, some of these thoughts, and if any other people from Africa in the conversation could share that, their tough stuff that's happening in their part of the world. Even South Africans, if they can share, like Steve, etc. So please feel free to step up and put your hand up, and we could then manage the conversation like that. I see that Rudolph, you've got your hand up. If you'd like to introduce yourself, you're welcome to do that. And you can actually share any stuff that you have on what's going on in your part of the world on COVID. Rudolph, you want to introduce yourself? Just unmute yourself and you can go for it. Sorry, have I not allowed you to talk? Sorry, I understand what I'm doing. So sorry, I'm going to allow everyone to talk. Sorry, anyone who's now able to talk, please feel free.
Hi, can I?
Hi, go for it. Innocent, you can start, and then we'll go to Rudolph.
Okay, thanks, Shabil. Just to share what is happening here in Uganda. So far, we have 55 confirmed COVID-19 cases, and the first case was confirmed on the 21st of March. And since then, there has been progressive increase in the number of cases, though a little more slow with some days of having no one testing positive. And these last few days, we have one case per day, I think in the last 5 days. All of them are being managed within the hospital. But the good news is that they all have, a majority have mild symptoms, and we have really had a few cases with moderate symptoms. So no one has required ICU or any other high. Yeah, so most of the cases are mild, and most of the cases also of people who traveled from the Middle East, mainly from Dubai, because they are being got from the quarantined population. But we have also had tracing of community transmissions, which we haven't got anybody, because there was really active isolation of the people who are coming in. The case that was confirmed 2 days ago was of a truck driver who entered Uganda through Malaba from Kenya. So now the focus is actually on the truck drivers. So we have only identified one person who has tested positive out of 300 truck drivers tested. So the focus, we are under total lockdown in the country. So the focus now is on really trying to flatten the curve. And I think the results are quite promising. Of course, the lockdown has been a bit challenging in one aspect, in that the other essential medical services have been severely affected. Like today, I am just from the hospital. We don't have people coming in. So our worry is that this lockdown has made the patients are not able to move to seek other medical services. So we are really wondering on how we should get around this. And I would really love to hear how other people are providing the other essential medical services within this COVID problem. We are really hopeful that we shall not get serious cases from the community transmission because of the wicked system. Like we have, I think we had 10 ICU beds in the whole country before the COVID, and the COVID wave forced the government to buy another 40. So we have now, I think, a total of 50 ICU beds for over 40 million people. So I think that is really our concern, but I think we are still lucky that we have mild cases. Otherwise, if we really get very many cases that need intensive care, we are really very scared that something a little more disastrous can happen. I think so far that is how we are, and we are still hoping that the cases are not going to seriously expand. The other concern that is coming up these last few days is that there is a rapid increase in the number of the COVID cases in our neighbors in the south, in Tanzania, and because for them they are not under any lockdown. So people are saying probably the spillover effect may actually affect us because we are aware of our porous borders, but we are keeping the fingers crossed that the effect will not be as bad as we may think. I think briefly that is what I have to say concerning our situation here in Uganda.
Sounds very useful. Thank you, Innocent. It's useful insight. Any comments? I see that Rudolf, is it Rudolf?
Yes. Can you hear me, Shabir?
Yes, yes, thank
Okay,
you, Rudolf.
excellent. Okay, good afternoon. I'm Rudolf Schumacher. I'm the former director of the Family Medicine Postgraduate Institute. Since a couple of weeks, I'm logged up in Germany, in the European summer. But I keep close contact to my people in Lesotho. Yesterday, we had a meeting online with all the different registrars in the districts and all our family medicine physicians. So it was quite encouraging. Maybe some of them, or one or two of them, are already joining now this meeting. I'm not sure. But what they shared yesterday, specifically those who are in government service, was at least not discouraging. Actually, there's a lot of leadership they take when it comes to training their own staff, setting up specific places for COVID-19 patients. And also going into the communities and being part of increasing knowledge in the community on the virus. What they all complained about is they wanted to be better prepared to talk about the virus in the communities and also among the staff. Now, my impression was just the mere fact that the virus does not seem to be as virulent in Southern Africa as it is in other parts of the world. For instance, here in Central Germany, in Central Europe, makes it more difficult for the people to really accept the very harsh measures, and also for family physicians or for doctors, for nurses, to explain to people why all of this seems to be necessary. So it was much easier in Germany. Well, I realized that people saw people dying after being infected, and they started believing it. So it was very easy, actually, to convince people to keep up the measures, the lockdowns, which was introduced everywhere. So those two issues, I think we have to consider when we see the situation in the southern part of Africa. So people still have to be convinced that the danger is there, and I think it requires even more inside knowledge for each of the registrars, for each of the doctors, for each of the nurses, when they start talking about the virus, including their own fears, because it may easily happen that even they themselves, they start doubting. Lesotho has not seen any case of an infection with COVID-19. And we don't know why. Why not? Is it because there was no testing? Is it because it's just excellently managed? Maybe the borders were closed very early, but all of that leaves a little bit of a doubting, and I think this is seems to be specific for Southern Africa and for Lesotho in specific. Okay, that is what I wanted to share for now.
Thank you, Rudolph. I think it shares similar challenges to Uganda in the sense that there's a very low number of cases and questions are being raised about, are we missing it? Or is there something different happening? I think that's a common thread. So that's useful. I don't know if anybody in other parts of the continent would be able to speak. Steve, maybe you can share some of the insights from South Africa and some of the responses in the Western Cape. I'm not sure if anyone else who's got some background in Africa could speak. Tessa, maybe you can also share some of your thoughts. And then we can just take questions and comments, and I can add a little bit from the South African perspective. Go for it, Steve.
Yeah, Shabir, the question in our minds is why is the spread and severity of the disease apparently less in Africa? Is it just a function of a lower rate of testing? Or is there genuinely a protective factor in the African populations? For example, this link with BCG, which has not been proven yet, might indicate that previous exposure to TB is protective. None of this has been shown convincingly, scientifically yet, but we are seeing a much lower case fatality rate and a slower spread to date. And everybody's trying to understand why that is. I find it fascinating. There's some in vitro studies that show some associations that show BCG rate mirrors that of the lower COVID infectivity and case fatality rate. So at the moment it's just conjecture, but certainly we would need to find out why Africa so far is different.
For sure. I think that I think that we have to understand that dynamic, and it's going to pan out in the next 2 weeks to see whether that's inherently so, or are we missing things? Because as soon as the mortality or the morbidity presents at the hospital, we're going to know the difference that we're not testing, as opposed to the fact that there's some sort of protectivity we have in Africa. Amanda, would you like to say something? Any other comments from anybody? Please put your hand up. If you have a question or comment, I can share a little bit if there's no comment. Any comments? Yes, Amanda.
Not really, because I don't know. I'm learning from your situation, sure. Colleagues. Thanks.
No problem. No, fine. So if you want to comment or question, please pick up your hand, and I think we'll have some inputs maybe from colleagues in the WHO as whether there's any thoughts around that. So let me just share a little bit of what's happening, and it's a little bit updated from last week or 2 weeks ago. I think in South Africa, the ministry, we're the hotspot, so there's lots happening, and a lot's happening in Johannesburg, and we have a situation where most of that came in through travelers, as I think is seen in Uganda and other countries. Once it's come into the country, it seems those contacts have created a little bit of a spike in it, and then it was expected that there'd be community transmission, and that seems to be not as quickly moving along as it is. And the big question is exactly the same. What is going on? Are we not testing? I'm just from a meeting that was held in Alex in a community that's pretty more vulnerable. And we in fact had a review of the process of care that's happening. and we are not testing anywhere near the number that we should be. As I say, that might be a problem, and we are not testing. It's definitely an issue. I mean, for one center like Alex, which sees, well over 600-700 patients a day, in which you might have 100-150 of them potentially coming in with a cough, they've only been referring up to 10 at max people for testing. And that's not because the guideline is restricting it. So the guidelines have actually, the country guidelines have changed since the beginning of the week to say anyone with a cough ought to be tested, and that it should be tested, in facilities. But the facilities are not equipped and the testing's not happening. I think one of the key things that I want to point out from an African perspective is that when I think retrospectively, if we were to manage the epidemic, it would have been to do exactly what was done in Lesotho, is to shut the borders and then to make sure that anyone comes through it has in fact is quarantined, and it just messes up any travel, but that would be the requirement, rather than lock down the country, because I think that has really serious consequences. And then to chase up anybody that presents. But I mean, if it is that you have porous borders and it starts getting community transmission, then like in South Africa, it's a little bit unsure now. Where are these patients? And we are finding them in completely random spaces, just popping up, and largely happening because of the private sector testing. So the volume of testing happening here in South Africa is almost 3/4 now private sector, as opposed to the public service. And the public service is almost rationing the testing. So it could very well be that we're missing it. I think that we'll see that panning out in the next 2 weeks when the morbidity reaches hospitals and we figure that we are clearly missing things. From a primary care point of view, we started in terms of trying to address the epidemic in Johannesburg by saying that we need to manage patients coming into the facility in terms of creating a separate queue for those who are coughing, any symptoms. And those initially were, in fact, we left it at that time saying the same that is now operative. We said anybody coughing with a fever, respiratory distress, and who has, what's the fourth thing, a sore throat. So those were the criteria we used. The original criteria were travel history and contact, etc., which we said will fall away quite quickly, which it has done this week. We applied that principle and said, please arrange it. What has happened is that the government, in a state of panic, because facilities management-wise, despite this guidance in the country and in the province, did not actually manage themselves very well. So what people did is reactively push people outside and say, we are going to keep the social spacing happening in the facility. And so they had let in only one person at a time or 10 at a time. And then outside the gates, they're just lining up, like a mob. And the managers at the top felt, no, that's clearly a challenge. And we need to, in fact, have a situation where this is managed. And what the Gauteng Department of Health landed up doing is shutting services. So they've sent out a circular at the last week saying nothing but emergency, primary care shut down. And at the same time, this week, we, myself with a pair of infectious disease specialists, public health specialists, have said that we need to implement this specialized approach where we manage people separately. And they've come in and talked about a way to manage it using zones, etc., which I can talk a little bit about. But said that is a way to retain services, but to manage the service better with regards to suspects coming in. And it's been no more than saying, let's enhance this idea of a chest clinic right at the front gate by saying, let's get everyone outside really well defined in terms of their social, physical spacing, with lines on the ground, bringing them in, having a person that will spray them with disinfectant, then having a 2 meter is further on a triage station that would be done deliberately, allowing people to be checked on, do they have these symptoms, and then split into two streams. One is blue, being they can go into the facility, we'll have social spacing there, but that services can continue. And then creating an orange zone, which is really going to be kept, like we said, at the chest clinic, close to the front gate, but in a circuit that goes through the process of a patient being seen, tested, and then sent out home, and managing the sort of acuity levels as needed. So that's what we've been doing this week. And we hope that we can negotiate with the Gauteng Department of Health to say, please, shutting down services is not the option, because this problem is going to be escalating potentially and continuing for pretty much up to a year. And so that will be devastating to current services where people are sent off as in non-emergency. So I think we really have a serious challenge. WHO has issued that guideline on continuing services, and I think that we can in fact have them joining us. I think that Karen Kinder is around, and I think that Karen could also share, but we have people from within the services within the WHO that could speak to it, Sarah and others. So I think just in closing, I think that there's some really ham-handed decisions in South Africa about managing it. One other thing that has come out is that our initial African response was to actually shut down, you might say it was a beginning lockdown, trying to reduce large gatherings, etc. But within a space of a week with the escalating numbers, we went to a full lockdown, which has not been as effective as all that. We still have people not quite following that guideline in the kind of African environment where news doesn't reach, etc. So this past week, as a third or fourth week in the intervention, the lockdown has been extended, and government has decided to add in the element of going through the entire community, door to door, screening people and then testing them, which we found to be problematic. When they have not prioritized clinics where testing can occur. So they've created more designated sites in the community. So in a sub-district of 20 facilities, they said 3 facilities, and the screening in the facility and in the community will be referred to that particular site. But that can be 2 taxis away and patients may go missing, and then they jump into taxis. So it's fraught with problems. And so we're really trying to push ahead to say every facility needs to test, every facility needs to manage these COVID patients separately in this orange zone and manage them very well. And so that's where we are at right now in South Africa. Any comments? I think we would I would appreciate some comments. Maybe others who are on the call from African countries, feel free to step up. And if not, anybody like Karen or Steve, if you'd like to add, and then perhaps people from WHO, Sarah and Aicha. Yes, go ahead, Sarah. Thank
you. Thanks very much. I mean, there are a lot of important points, I think, or points, at least points for discussion that you've raised. I think the first of interest is there's been a lot of emphasis placed on testing around the world, and in terms of looking at the reported number of cases as a means to measure the burden of the outbreak in a particular country. But what you said rightly was that there are many caveats with this because the testing strategies vary between countries. And also there is an availability of test issue in many cases. So looking at the mortality might, give a better estimate or understanding at least of the burden. And we don't see much discrepancy between the mortality rates in the African region and the cases. So it seems that, I mean, we want to, I guess, make a tentative claim that perhaps what we see really is the case, but the reason for that, we're not 100% sure why, as you said. The other important...
Sorry, Sarah, if I may just ask you, so you're suggesting that in comparison to the rest of the world, the progression based on the fatality rates is less in Africa?
Well, what I was trying to say is that if we had, if we looked at the number of cases reported, we say, oh, well, it's compared to Europe, we see a very slow trajectory of growth, and it seems that it's less affected than other regions. However, if we looked at the mortality and the mortality was really high, we would then assume that the number of cases wasn't then representative of the true burden within that country. But what we see, I think, in Africa is that the mortality sort of matches the number of cases. So we, even though we look at the number of cases in many parts of the world, in Africa, it seems to be, at this point, it seems to be a reasonable reflection of what's occurring. I think the other important point you mentioned about managing patients in the community, what we're seeing in many places is that there's a lot of emphasis on identifying a patient and then isolating that patient. And whether you identify that patient through testing when it's available or through the symptoms, it's really the steps that come afterwards that are extremely important. So once a patient or a potential patient is identified, making sure that that patient is then isolated, and either isolated in a health facility or at home when the disease is less severe. But then not just stopping there, but really going through to the contact tracing side of things. So being sure that there is a list that is made of people who've been in contact, and then the contacts are not only informed, but quarantined and monitored. So if they do potentially become cases, then, you know, the process sort of starts again with them. And even in Europe, we see that the chain it stops at that first identification of a patient. And really, if we're wanting to make sure that we break those chains of transmission, it really is following that entire process through to the monitoring of contacts. Aicha, I don't know if you want to make any further comments.
Sarah, I think you are completely right when you are saying about the contact tracing. And I'm going to do a small comparison with when we were working on Ebola. The main, I'm going to say one of the main success was to be able to do a contact tracing to make sure that those contacts are followed properly. And then once the patient or the contact was getting infected, to be isolated in a proper way. It saves a lot of lives. Regarding the numbers of patients that we have in Africa, as Sarah said, it's important to know that unfortunately we are lacking tests in Africa. Not everybody is, I'm going to say, having easy access to tests. And also when we look at DRC, at Kinshasa, for example, the disease started with people coming from outside the country. All the first sick patients were also coming from outside the country, coming from France, Belgium, or even from Middle East. Then it started in a not used community, as we could say, because it starts in a community that they are most of the time literate, they can travel, they have the money, they can have access to some healthcare. It did not touch directly the same population as we have in some other outbreaks, like, for example, cholera. We have another type, I'm going to say, type of community that is easily touched by the disease. Here we started in another way around. Then it's important to sensitize the community on if they feel sick, to show them where they can get, I'm going to say, health care, but where they can get it in a safe way. Because we know also the burden of HIV and tuberculosis, for example, in KwaZulu-Natal. We know that it's really present. People coughing, we have many of them. Then maybe they will not make the difference between this current disease and the tuberculosis or the, you know, I'm not going to say regular, but quite often respiratory disease. Thank you.
Thank you. Anastasia, do you think you could share a little bit of what's going on in Kenya? I know that you're having the hitch with connectivity, but we'd really appreciate some insights into what's going on there. Do you want to chat to us a little bit? Anastasia, can you join us?
Let me see. Hello, can you hear me?
Yes, yes, go for it, Anastasia. Great,
Okay.
we can hear you very well.
Thank you very much.
Please
Good
share
afternoon. I'm a pediatrician. I work in a sort of, well, it's not really rural, but more or less an urban healthcare facility. Our experience so far, a lot of mirroring from what is being seen in what has been described in Uganda. So we had a lot of imported cases, and then from those we were able to have them quarantined in specific facilities, and so a lot of the positive cases now are from many of the cases who are on follow-up and been quarantined therein. There's a good mixture of both pediatric and adult, although of course the adult cases are predominant. We have had about 11 fatalities, but in all of those, what has been uniform is the fact that they all had comorbidities. So they were diabetics, hypertensives. One of the children actually had a plastic anemia, and so those were some of the interesting issues about them. I'm a general pediatrician, and I think my question specifically would be just to hear a bit about the experience of pediatric cases all over. What we have done so far, at least in terms of our protocols, is that we are encouraging all children who come in with features of severe pneumonia to be isolated and to be tested for COVID-19. Even though, I mean, that is now a sort of a new addition to our protocol. So maybe we are hoping that maybe we'll be able to pick up a few more cases from that, but I don't know if that is similar elsewhere, and if, you know, the pediatric cases, generally ours are tending to have mild symptoms and they tend to do very well. Thank you.
That's useful. So your question is actually around pediatrics. I can share a little bit. Would anyone else like to respond to that? The question of pediatrics globally. Anybody who has a sense of the global picture? My impression is that it's mostly an adult phenomenon, older person being, in terms of fatalities, and very much your experience is the global experience of mild symptoms in younger children. Anybody would like to respond? Karen, do you want to talk about that, if you have a sense of the picture clinically? Steve? Yeah, Karen, go ahead. Well, Sarah. Yes, Sarah.
I think just to confirm what you're saying, we see globally that children tend to have much milder disease. However, I think important to note that they can be infected at the same rate as adults, and they can transmit the virus in the same way. So although they are less affected in terms of severity, they certainly do suppose
spread it around.
Remembered exactly. So.
Yeah, so I mean, I think the picture we're seeing, just thought about managing patients. We actually faced with clinics telling us, well, how do I manage the children? And we said, well, actually, you don't want children to be running around, knowing that they're a vector of sorts. They move it around. But people were concerned about the IMCI clinics and saying we'll run them inside. We said, no, everyone should be managed as if they're coughing, should be that, which is very common amongst children. And people were really saying, well, those are mild coughs. No, you'd have to treat them as potential COVID, because they could very well be having the COVID and transmitting it to others. So you need to manage them in that respect. We might not test them as frequently as we test our elder patients, depending on our constraints, which we had. So we might go about it slightly differently, but they're just as much potential COVID patients. Aicha, yes, go ahead.
Yes, my concern is for Dr. Anastasia. As you said that you were going to test all the children, for the time being, how many children or an average of children that you tested? And what is the outcome when the child is positive? Are you also inviting the caretaker to be tested also? How does it work?
Yes, sir. Thanks. Anastasia, can you respond to that? Just to share some insight as to how it's happening.
Okay, so at least so far, for the children who have tested positive, they have needed to be, and those who have needed to be in quarantine, they have been in our quarantine facility. So those have been with their caretakers. The other one whom we had, unfortunately, was actually a diagnosis posthumously, because they came in very sick, went into ICU, and then the test results came back later.
Okay. So you're suggesting that the testing rate is the outcomes of those testing? Did you know what they...
Sorry,
the outcomes of the testing, do you know whether they tested positive? These are positive patients.
Yes, we are able to, at least currently there are about 4 patients who are pediatric and are COVID positive.
Okay.
Yeah.
Okay. Does it answer what you're raising? I'm sure, Aicha? Does that satisfy your question?
Yes, thank you. Thank you very much.
Thank you for that. All right. Well, we're coming to the hour. I don't know if there are any other contributions that people have. If they'd like to share anything, I'd certainly like to get any other views. And Rudolph, if you have anything to add on an innocent from, as insights from your country, if you want to add, and if anyone else wants to come into it and share some thoughts, feel free to sort of put up your hand.
Can you repeat the question, Shabil?
Yes, you can hear you. Go ahead, Innocent.
Yes, I didn't get what you wanted me to talk about.
Anything you'd like to add? Anything you'd like to add, and think if there's anything you'd like to share beyond...
Yes.
Yeah.
I think the other thing I would like to add is really the concern that happens in many other African countries is the way how the lockdown was managed, how is being managed. For example, we were just living normally, and all of a sudden the president declared the total lockdown. And to be honest with you, for the whole week, I couldn't travel from my home to the hospital because there was no previous arrangement. And we also get very many, a lot of people complaining in the newspapers, both in the media, both in the print and electronic and on social media, of patients who are stranded, who can't access health facilities. And it is actually just 2 days ago when I was only given a movement sticker that I am now able to freely move from home to the health facility. So I think the overall preparation for the lockdown did not cater for the provision of the other essential medical services. And then the debate is that, and I liked what Sarah was talking about, the measure of the disease burden, because the debate is we are likely to witness significant mortality from the non-COVID usual problems. For example, as I said before, all of the patients have mild symptoms, and actually we are informed that a good number of them are asymptomatic. So people are saying, yes, of course we don't know what the explanations why we are seeing a mild course of the disease, but the issue is why should we lock everything down, particularly the essential medical services, and we forget about them, and then a lot of attention is paid to COVID, yet we are actually seeing mild cases. So, but of course, that becomes a political question, and no one has the answer for it. Then the other issue is, in the total lockdown, some people are allowed to move, particularly those who transport cargo. And the few cases which have been isolated were actually the cargo transporters. The truck drivers are tested on entry into the country, but they just pick a sample and then they allow them to continue. And the latest case, which tested positive, had actually spent 2 days driving a trailer within the country. Now, the question was, should the trucker driver wait for the results, because it takes about 36 to 48 hours to get the results back. We have only one testing center, which is only a government testing center. We don't have any other lab that is able to do the test. So I think given the issues within our systems in general, we still have problems with the management of COVID-19 because we have a lot of unanswered questions which really no one knows how to deal with them, but which pose a clear risk. So we still have a lot of issues, but the good news is that the essential medical services are slowly being brought back, and hopefully everything should be well and moving on as we try to get back to normal.
True. I think that's a big problem in Africa, is that there's been a bit of a knee-jerk reaction and perhaps a very dramatic cut down, sort of lockdown process, and it might be an overkill. So I think that's a problem that other African countries, I think there are lots of lockdowns in Africa with very small numbers, but clearly from what you're telling us, Innocent, the borders are still porous with truck drivers. And people are actually locked down when that's the wrong thing. It should be the borders properly locked down. Any other comments? I don't know if Rudolf, you want to add any comments from your perspective? Have we covered some of these issues? Does it provide some useful insights? I think that collectively we need to ask, what are the challenges and whether we can make it known at a higher level. I'm sure that Sarah and Aicha will take these comments, and maybe Karen, if you can give us a comment as well, how this might reach the ears of high authorities. Go for it, I think, Rudolf.
Yes, Shabir. I think you can hear me. Yeah?
Yes.
I think it answered some of the questions I raised in the beginning. I also tried to compare what I see here in Europe happening and compared with the situation in Southern Africa and Africa in total. Okay, let's hope we get some answers very soon why the situation is different. The other issue of making sure that whoever is at the front line has enough insight in updated information is also important. because in a situation where you are not having a lot of positive patients, it turns out to be, if there is one suspected infected patient, and that was reported from different places in Lesotho, it happens that people are getting easily nervous, not knowing what they do, and not knowing whether they do the right thing, because they have never seen a positive patient. So also on that side, I think we have to make sure that we protect the health workers and make sure that they are not necessarily putting themselves in unnecessary danger. I don't know whether there was a webinar, I think, this morning by WHO, which probably was very helpful. It was on workplace issues for health workers. So I think it's also important to be relaxed and not getting nervous because there is one possible case of a disease which I am not sure about. So with that,
thank you.
let's hope we get a bit more information. But thanks for giving us the forum to talk about those things. Thank you.
No, thank you very much. I think that we are, in closing, thank you all very much for attending. I think that this is an opportunity to share, and we want to try and get a feel for different experiences across the continent. We have this regular webinar on a weekly basis at this hour. I think it's an opportunity to understand the dynamic. If it turns out, by the week, that we are fortunate, protected, I think we'd be really grateful for that. If it doesn't turn out and that we're missing cases, I think that would be disastrous. But I think that's all the more reason for all of us to meet, talk, and share our ideas, share our thinking, and have the opportunity to learn from each other. So if there are no other comments from any of them, I think perhaps Sarah, you would like to close, make a few comments in closing, and we can close after that.
Thank you. Just very happy to be here and to listen to the discussion, and to really for us, it's an important opportunity to provide ourselves with a reality check. Obviously, WHO produces a lot of guidance that is the gold standard, but in many settings may not be very easily implementable, and it's good to have this feedback and to do discussion just in terms of the whole discussion around the restrictions, the movement restrictions, and it's something that we have been battling to work through with countries to say that yes, we need to meet the public health objectives, but not in a way that comes at an extreme cost to economies and societies. So yeah, we hear that. Thank you.
Great, thank you very much, and I hope that you will sort of take some of these sentiments to a high level and perhaps influence. I'm not sure that we haven't had anyone from WONCA, WHO-Afro, but we'd really appreciate him joining the conversation and see if they've got engagement with government that can advise them better and respond better to what's going on the ground. So I think without any more ado, I wish to wish you all a good weekend. Thank you all for joining us. I do apologize, we didn't have a registration or a type of webinar, which might have contributed to the low attendance, but I'm sure that we'll fix it up by next week. So keep your eye out for the next webinar. next week, Friday, same time. All of you, keep well, keep safe, and enjoy the rest of your weekend. Bye-bye, everyone.
Goodbye.
Bye, Shabir. Thank you.
Bye, Steve. Bye-bye.